Hi, welcome. Thank you so much for joining. Welcome to Windsor Dermatology's Healthy Skin Highlights. Tonight is our fourth episode of a 14 lecture series. Throughout the lecture series, the providers at Windsor Dermatology will discuss multiple different common dermatological issues. There will be time at the end of the presentation for questions. If you have any, please leave them in the text box below, and Dr. Bagel will address them at the end of the presentation. If you are interested in our Healthy Skin Highlights coffee mug full of goodies, please drop your name and how you found out about the chat in the text below, and we'll contact you privately if you're the winner. Tonight it is my pleasure to present Dr. Jerry Bagel. Dr. Bagel is nationally recognized expert in treatment and research of psoriasis. So much so that he is recognized as a member of the National Psoriasis Foundation Board of Directors for the last 4 terms. Dr. Bagel is regularly invited to speak across the country and internationally about psoriasis and its treatments. He has published extensively on the topic of psoriasis in such journals as the Journal of American Academy of Dermatology and the Journals of Drugs and Dermatology. Dr. Bagel also gives back to the community by offering a renowned clinical trials department for patients that either have no insurance or had hit a roadblock in treatment. We at Windsor Dermatology are thrilled you took the time to join us for this exciting episode of Healthy Skin Highlights, an educational web series with Windsor Dermatology hosted by Dr. Jerry Bagel. And now it's my pleasure to introduce Dr. Jerry Bagel, everyone.
Good evening, everybody. For the last 40 years, I've been taking care of people with psoriasis. The good news is that right now there's some really good treatments for psoriasis that we didn't have before. This little girl named Lucy, I took a picture of in 1983 when I was a dermatology resident at Columbia Presbyterian Medical Center. Lucy was 6 years old at the time, which means now she's about 43. I don't know where Lucy is, but I wonder, what kind of life did Lucy have? Did Lucy develop psoriatic arthritis, like 1/3 of the people that have psoriasis? Did Lucy develop severe psoriasis? Did it interfere with her ability to have interpersonal relations with other people because she was stigmatized? Did Lucy become obese? There's a high frequency of obesity and diabetes in people with psoriasis. Did she find a dermatologist that was willing to help her, not just throw some topical ointments on her, help her get really better? When she was 17, when she went to the public swimming pool, was with her best friend, was she asked to leave by this attendant because they thought she had a contagious disease? That clearly would have messed up her day. But more than that, it would have affected her long-term self-esteem. People with psoriasis have an increase in depression, anxiety, social withdrawal, and increase in suicidal ideation. So what is it? Well, look at this. It's a red, raised, scaly plaque that can be on an elbow, a knee, the scalp, the palms or soles, on 5% of the body, which 1% equals your palm and fingers. 100 of these equal your body. 1% is one palm. 5%, can you think about? 10% is already considered severe. More than 10% clearly severe. But some people may have it extensive like this in the scalp. That keeps them up at night, awake, scratching, itching, unable to sleep, and they go to work tired. And it can be very extensive. It can be very widespread, but the telltale clinical symptom, it's almost always 99% you can make the diagnosis by looking at it: red, raised, scaly plaques. Look at how thick that scale is. Using creams or lotions, putting it in the scalp, very difficult to get in and get out and therefore people aren't compliant when they try to treat their scalp psoriasis. So it's really a long-term nuisance, and now we have agents that are available that are more aggressive to treat scalp psoriasis with. Also, what's known as inverse psoriasis. This could look like a yeast infection, but in fact, this is psoriasis. Inframammary, axillary, under the armpits, in the groin, perianal, irritating, oozing, odorous, tough to deal with. Let's read this. I'm just going to pause for about a half a minute and let everybody read this. John Updike, famous American author, The Journal of a Leper. In fact, in antiquity, people with psoriasis were put in leper colonies because leprosy had many cutaneous manifestations, as does psoriasis. They didn't know the difference, and they put them in leper colonies where they got leprosy. And people in antiquity, it was told about that they were sometimes thrown out of their communities. And when they went out into the desert, we know that sunlight helps make psoriasis go away for a while. What happens then when the psoriasis went away, they would come back into the villages and they'd have to ring a bell in order for them to be looked at before they would be allowed back into their towns. Psoriasis can also, like I said before, affect the joints, and this can be very debilitating. Psoriatic arthritis occurs in about 1 out of 3 people that have psoriasis. It usually occurs about 7 years after the onset of psoriasis. And the most common time that psoriasis occurs is in adolescence. About 1.5% of the United States has moderate to severe psoriasis, about 4.5 million people with moderate to severe psoriasis in the US alone. And so about 1.5 million with psoriatic arthritis. It manifests itself as painful knuckles in the fingers, stiffness in your fingers and joints when you wake up in the morning, stiffness in your fingers or toes when you wake up in the morning. You see down to the right, there's something called dactylitis, swelling of an entire digit. And notice the nails are very abnormal. This is not fungus. About 70% of all people with psoriatic arthritis have nail involvement. And nail involvement can have major impact on the quality of life of individuals. In addition, going back to psoriatic arthritis, there's an entity known as enthesitis, where a ligament or a tendon attaches to a bone, like plantar fasciitis, the bottom of your foot. If somebody has psoriasis and plantar fasciitis, there's very high likelihood that that person has psoriatic arthritis. It also can be a plantar fasciitis in the Achilles area, the costochondral area, the back of the spine, also can be involved. As I mentioned, nail involvement can have a major impact. Now, people without psoriatic arthritis, about 35% have nail involvement. And with psoriatic arthritis, about 70 to 80%. Now, with significant nail involvement, it can have a major impact on what you can do with your hands because it can be very painful, or it can be cosmetically very upsetting, to the point where a study was done that showed that people that have 15% body surface area and no nail involvement, their quality of life was equal to someone who had 8% body surface area and nail involvement. So twice as much increase in impaired quality of life with nail involvement. Now, I mentioned before also about certain what's known as comorbidities. These are other types of medical phenomenon that are associated with psoriasis. And one of the most common is obesity. And we see about twice as many people with psoriasis are obese compared to the normal population, compared to people that do not have psoriasis. Twice as many. Like, for instance, the average weight in the United States is about 75 kilograms. The average weight in psoriasis in clinical trials is 90 kilograms. So that's about 35 pounds more for each person that's a psoriatic compared to a non-psoriatic. Where it gets even more dicey is that we could see here with diabetes in somebody that's between the ages of 40 and 49, about 15% have diabetes that are psoriatic. compared to only about 3 that don't have psoriasis. Hyperlipidemia, high cholesterol, 3 to 4 times as high in the psoriatic population. Hypertension, 3 to 4 times as high in the psoriatic population. Coronary heart disease, much higher. And really what goes down with this is that Dr. Joel Gelfand from the University of Pennsylvania did a major analysis of people in Great Britain and found out if you look at, for instance, in the 30 age group and the 40 age group, that brown dots, you see that there's about 4 times as much heart attacks and strokes in a 30-year-old with psoriasis compared to someone who does not have psoriasis, and about 35% more in the 40 age group. So what does this mean? This means there's a lot of inflammation going on in the skin. Psoriasis is caused by an increase in white blood cells producing certain molecules that make the epidermis grow too fast. Normal skin takes 28 days to grow. In psoriasis, it takes 4. Growing 7 times the rate of normal, it doesn't have time to mature properly. And it gets flaky and scaly and red, just like what you see in the pictures. But the underlying basis for this is the hyperregulation of the immune system. And this immune system is producing not only psoriasis, but those same molecules that are excessive in the skin are also in the blood. And when they're in the blood, they increase your risk of atherosclerosis. And when they increase your risk of atherosclerosis, they increase your risk of myocardial infarctions, heart attacks, and strokes. To the point where, in fact, there's about 5 years of lost life in the psoriatic compared to the non-psoriatic population because of the increased amount of heart attacks, strokes, and sequelae from diabetes, such as kidney dysfunction. On a personal level, we see how much psoriasis impacts the social and sexual lives of the individuals. Right up top to the left, sexual desire, appearance, has a negative effect upon their appearance. Looking down below, lower sexual frequency, lack of enjoyment, avoidance of sex in 50% of all people with psoriasis. Only a quarter want to have children. And on the right, sexual ability, lots of pain because of scaling and redness, erythema, itchiness, bleeding, and going down below, 60% interferes in intimate relations, and even there's been discussions and articles that show that it changes the impact of what people want to do in their personal careers. So, with psoriasis, we have a spectrum of not so bad, localized, which can still have a major impact, to moderate to severe. But if you have a little bit, you might be able to get away with treating it with topical corticosteroids, or there's now combinations of topical corticosteroids and vitamin D, or topical corticosteroids and vitamin A. Now, there's some really good steroids out there. There's class 1 steroids. They're super potent, but you can't use them too long because they'll thin out your skin. And you can't use them under your arms or under your breast or in your groin because it'll really result in what's known as stria, like breakdown, like, stretch marks. And those could be permanent. So therefore, localized, we can use topical steroids. We can use eczema laser, but that's for localized disease. Once you get into moderate to severe psoriasis, there's a whole new ballgame. For instance, there's oral therapy, which we usually don't use that much because, for instance, Otezla, which is the most popular, only works okay about 1/3 of the time. And it does have some side effects that people don't like nausea, diarrhea, headache. Cyclosporine was the first drug that was ever used to treat psoriasis in 1980 in the University of Pittsburgh, where they put somebody who had psoriasis and a kidney transplant, and they were using this to prevent kidney transplant rejection, and the psoriasis went away. So that was the ushering in that the immune system was involved in psoriasis. We use cyclosporine now rarely in crisis management of psoriasis, like actively flaring, terribly bad. You can get the pill today because some of the biologic agents might take 2 weeks to get, so you might treat someone aggressively with that. Acitretin is a vitamin A pill that is like Accutane that we often use with phototherapy to help make light treatment work better, but you can't use it in women of childbearing age because it's teratogenic. Methotrexate's a long-term staple in the treatment of psoriasis, but it can result in liver damage. And many of our patients with psoriasis, because they're either obese, diabetic, and I didn't mention there's a higher frequency of alcoholism and also hyperlipidemia, all increase the risks of liver dysfunction. So to use methotrexate is really not being done that much, except sometimes as an add-on in the treatment of psoriatic arthritis with other biologic agents. Phototherapy has been used for years. The first group of doctors that were using phototherapy was at the Mayo Clinic in the 1920s, the Gueckerman Brothers. The Gueckerman Brothers developed a system where people were hospitalized for 1 month at a time. And actually, when I was a resident at Columbia Presbyterian in the 80s, this was still being utilized. People would be hospitalized. Every night, they would put crude coal tar all over their body, put a pajama on, wake up in the morning. You could see the tar just seeping through the pajama. And then they would be soaked in a tar bath. They get moisturizer ointments. And every day for a month, they'd stand in the light box like this and get increasing doses of ultraviolet B light. And after a month, they'd clear for about a year. They'd come back and do it again. Well, today, and for the last 30 years here at Windsor Dermatology at the Psoriasis Treatment Center of New Jersey, we have treated many people very successfully with ultraviolet B light. In fact, we just submitted an article for publication that shows that, which hadn't been done actually, that shows that people that come in 3 times a week for 12 weeks, about 75% get 75% better or more. And it's safe. There's no increase in skin cancer from narrowband UVB. What ultraviolet B does is that, remember I said that the skin is growing too quickly, and the ultraviolet B hits the DNA of the proliferating cell and stops it from dividing. And so it basically stops it from dividing, and this over time, the skin goes to normal. There's also something called PUVA, where you take pills before ultraviolet A, and that works even more better, but there is a slight increased frequency of skin cancer after 150 treatments, which we don't do, but in the early days when there was nothing else, we did do. Now, the beauty of having psoriasis today is we have medications that work well and that work relatively safe. Before I get into talking about it, I want to say that one of the most difficult parts of treatment with biologic agents is what is going to happen in about 40 minutes. In 40 minutes, after the end of World News and the beginning of Jeopardy, and hope you didn't watch World News, but if you did, more power to you. In those 3 minutes, there's going to be 2 or 3 commercials about psoriasis. And they're all going to say just about the same thing. And that is, I have psoriasis, my life is terrible. Granted, I agree. I went on this medication and I feel great, but I might die of tuberculosis or cancer. And then who's going to go on this? Well, the fact of the matter is that's an oversimplification of the adverse event profile of these medications. Furthermore, the more recent biologic agents like Skyrizi, Ilumya, Tremfya, the 2 of which are administered subcutaneously only 4 times a year. And 90% of all people get about 90% better, and 65% of people clear with no increased risk of tuberculosis, no increased risk of malignancy, and no increased risk of serious infections. The biologic agents, such as Tremfya, Skyrizi, and Ilumya, are much more selective in their mechanism of action, to the point where their efficacy is better, they work better, and their side effect profile is better. There's no black box warnings with any of them. That's not to say some of the other medications aren't good. I mean, there's room for other medications. I mean, Taltz, for instance, is a very good medication, but it's contraindicated, in my opinion, in anyone who has a family or personal history of inflammatory bowel disease. On the other hand, it's FDA approved down to the age of 6, and you can get kids on it. And Enbrel is FDA approved down to the age of 4, and Stelara, which is another great drug, is FDA approved for kids down to the age of 12. So, and some of these drugs have better efficacy for psoriatic arthritis than others. For instance, Tremfya, out of the IL-23 category, which is Tremfya, Skyrizi, and Ilumya, is the only one that's FDA approved at this point for psoriatic arthritis. Taltz has very good efficacy for psoriatic arthritis, as does Cimzia, which is part of the TNF group. So what we have also done a publication that it will be published this month, actually, in the Journal of Drug and Dermatology, out of our own patients here at the Psoriasis Treatment Center of Central New Jersey. We went back from a group of people between 2018 and 2020. 100 patients, random. The average person was 45 years old, had psoriasis on 16% of their body, went on various biologic agents, and after 6 months, had it on 1.5% of their body. So therefore, they, on the average, had a 90% improvement in their psoriasis, and about 60% were clear. In addition, there were no serious adverse events noted that were related to the treatment of the drug. So we're looking right now at even a newer medication, two other medications. One is an IL-17 called bimekizumab, which is highly effective, and another actually is an oral medication by Bristol Myers Squibb that's 1 pill a day, and it doesn't seem like there'll be any monitoring required, and it works about 65% of the time, 65 to 70% of the time, but it's a pill. So some people might prefer a pill. So with that, I'm really, I have to say that, 25 years ago, 20 years ago, maybe even 15 years ago, psoriasis was pretty hard to treat. I mean, and here at Central New Jersey, psoriasis treatment in Central New Jersey, we have treated probably up to 5,000 people amongst all the providers. And right now, it's like I can look the patient in the eye and say, I can help you. And, 95% of the time, I think we can hit it out of the park. So the only thing I wish is that people would have bad psoriasis come here and let us help them, because there's no reason for them to go through all the comorbidities and the psychological aspects of their disease. So I want to thank you. I want to thank the people at Windsor Dermatology that put this slide, that put this whole thing together. I think it's remarkable that we could reach the community this way, and I'm happy to answer any questions that you have. And thank you. So these are the questions. What stress triggered psoriasis flares? That's a really good question. So there's a few things. Stress is number one. I've seen people got divorced, 3 months later, psoriasis flared. I bet you most people here are from Jersey, so you're going to all be able to relate to this. Superstorm Sandy. Superstorm Sandy, October 28th, 2012. I knew it because it was my birthday. About 3 to 4 months after Superstorm Sandy, I saw people who were not living in their house, may have been living in with their in-laws, might have been living in a motel, might have been living in their car, might have lost their job, might have gotten divorced, might have not had enough food. I saw the worst psoriasis in so many people in my whole life. And that was stress-induced, no question. So stress is way up there. There's a few other things, though. Strep infections. Strep infections make psoriasis worse, sometimes known as a guttate flare. There's little like dime-shaped macules all over your body. And to the point where if somebody has recurrent strep infections, occasionally we might even have them get a tonsillectomy to get rid of their tonsils so they don't get strep infections as often.
Certain drugs, systemic steroids, like, go to the doctor, you get some steroids for your prednisone for your psoriasis, not such a good idea. I'm not for psoriasis, for your poison ivy, not such a good idea because it can make your psoriasis flare. Certain medications, lithium, can make psoriasis worse. Beta blockers that people use for either migraines or hypertension. And other flares, alcohol. Alcohol, bad, bad, bad. Opens up those blood vessels, more white blood cells get into your skin, you start flaring more. I think that pretty much covers flares. Can outbreaks be seasonal? Yes. First of all, in the summer, because ultraviolet light helps psoriasis, people can go outside and their psoriasis calms down. I won't say it all goes away, but it calms down. In the winter, when the skin is dry and we scratch, there's a phenomenon called the Gueckerman phenomenon, which is trauma to the skin can induce psoriasis. Like you cut yourself, you get psoriasis. You scratch yourself, you get psoriasis. Why do people have psoriasis in the scalp so bad is they're scratching their scalp all the time and the trauma is inducing it. But I actually think, and I haven't gotten a lot of agreement, but this is my personal thing. I think psoriasis gets worse around pollen season. Like I think it gets worse like in the spring and the fall. I mean, so I think there are some seasonal variants. Do different people have different triggers for flares? Yes, they do, but I think it's all on a genetic basis. Psoriasis is not based upon one gene. Psoriasis is based on maybe 30 or 40 different genes. So different people have different profiles in which it can be exacerbated. What determines an eligibility for a clinical trial? It depends on the trial, but for the most part, you need to have a certain amount of psoriasis, like usually about 10% of your body or more. That's the usual guideline. You need 10% of your body, and you need to have it psoriasis for at least 6 months or more. And let's see, you have to be over the age of 18 usually. So over the age of 18 on 10% or more of your body, and those are, that's really it. And those are the big ones right there. And you can always call up and ask, they'll give you an idea if you tell them. But where some people get wrong is like, if you have psoriasis, you got to have psoriasis. Sometimes people have eczema and they think it's psoriasis, and so we need to look to make sure that that's what you have. And yeah, that's usually it. Sometimes there's different studies that require you to may have been on a previous medication and sometimes not. You might have to stop the medication you're on for 4 to 6 weeks. It's possible, or topical for 2. But, usually it's the criterion is how much do you have on your body? I think that's all the questions. So like I said, I'm really thankful to be able to take care of people here. We get our psoriasis patients in very quickly. I mean, if you really, suffering with your psoriasis, if you call up the front desk, you tell them that because we are the Psoriasis Center of New Jersey, we make every effort to get you in without you having to wait. And there's no reason to wait anymore because we got many good medications to help you out with these days. Okay, so thanks a lot, and look forward to seeing you if you need my help.